Hello and welcome to today's webinar, Advanced ICD-10 Strategies for Community Hospital EDs. Today's webinar will discuss benefits of ICD-10, how to avoid pitfalls and set expectations, clinical documentation improvement strategies, and common ED visits and ICD-10 expectations. My name is Amy Johnson, and in just a few moments we will be joined by our presenters. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. Leading our discussion today is Carrie McCrae, Kathy Jennings, and Elizabeth Morganroth. All three of our speakers work here at the T-System. Carrie is a RevCycle Plus consultant, Kathy is the manager of RevCycle Plus education, and Elizabeth is the medical systems business analyst. And now to kick off our presentation, here's Kathy, Carrie, and Elizabeth.
Thank you, Amy. Hi, this is Carrie McCrae. Just a quick review of our agenda as Amy had mentioned. We're going to talk a little bit about the benefits of ICD-10, give you some day-to-day strategies of how to avoid some of those pitfalls and setting the expectations correctly at your facility. We'll give you some defined pathways for your coders to direct them towards the ICD-10. And then we'll talk about some clinical documentation improvements, giving you examples of cases that are presented within the ED and what those documentation expectations are going to be with ICD-10. So to back up to the beginning a little bit, the current ICD-9 classification does not meet the needs of the current clinical practices or the medical and technological advances that have occurred over the last 20 to 30 years. So by improving the classification, this will help assist with the payment and the reimbursement process, and also the coding accuracy with greater detail of anatomy, cause, and severity. Ultimately, hoping that this will provide equitable payment for the resources that are used at your facility around some of these more complex conditions. ICD-10 will hopefully also help streamline some of those payment operations with more of the automation and fewer payer-physician inquiries and the phone calls that are made to the payers, the decreasing of the delays, and those inappropriate denials. ICD-10 will also allow us to analyze more of that detailed data to take a look at those patterns within the diseases and respond to the public health outbreaks. With ICD-10, there will also be a new pricing and reimbursement structure of the fee schedule, and again, improving the pricing scenarios based on the greater diagnostic detail. Much of the granular data generated from the ICD-10 can be analyzed and used to do population surveillance. So it can help policymakers determine the public health campaigns and detect epidemics before they get out of hand. The new coding system will also provide a treasure trove of data for public health researchers as they try to understand patient behavior and attitudes about risk-taking. So all of these taken into account with the detailed information on conditions, severities, complications, locations, and the need to expand the increasing code length to the 7-digit characters. All of these things will improve the operational process across healthcare by classifying this detail within the code to accurately process the payments and the reimbursement. So some of the challenges for the community hospitals, critical access hospitals, are the resources that are stretched right now to the capacity. Many of these roles are wearing multiple hats. Physicians sometimes have the reservations about the documentation required. And some medical coders don't want to learn maybe the new diagnosis. They may have experienced what ICD-9 was like and maybe just not be ready for ICD-10. IT staff is also stretched and juggling possibly other system upgrades, as there are other vendors that are affected, many vendors actually, that are affected by the ICD-10 move. So given your facility's resources, who will take the lead to educate all these stakeholders? There's many that are involved. These conversations of the impact of ICD-10 may be different with executives than the conversations you would have with clinicians. But it's important to understand the steps that need to be taken for a successful transition to ICD-10. Your HIS may not be the only vendor to work with to ensure that your readiness for ICD-10. Maybe your claims provider and their clearinghouses. Maybe you have payers that you're submitting claims directly to. Or there's compliance vendors, for an example, that you may need to work with as well. So understanding and planning and preparation is a key point to a successful move to ICD-10. The planning and preparation checklist of each of these departments represented can be examined possibly during this time, and also improving the workflow. So it's important to take a look at this and schedule meetings, create the team, even recruit some champions, and plan the education and training sessions to create and impact these assessments and these types of workflows. Again, communicating with the vendors and possibly even consultants, and maybe even hire said consultants. So now I'll pass it over to Elizabeth, who will move to the next portion of the presentation.
Thank you, Carrie. Without adequate preparation, the implementation of ICD-10 has disastrous potential to any business. Three major events in the last 15 years are, of course, Y2K, the implementation of various aspects of HIPAA, one of which was the 5010 implementation just over 1 year ago. As many will recall, there was a great deal of fear and uncertainty surrounding the implementation of infrastructure needs associated with Y2K. Fortunately, the world did not end January 1st, 2000. ICD-10 is part of the administrative simplification mandated by HIPAA, but HIT systems have been affected by aspects of HIPAA, including NPI and privacy procedures, to name but a few. Many providers felt the pain of 5010 implementation when vendors and payers were not prepared for the January 1st, 2012 deadline and experienced payment delays. What can we learn from these events to help make the transition smoother? CMS, through the rulemaking process, has extended the implementation deadline once again to October 1st, 2014, which gives the healthcare industry an extra year to be better prepared. The rocky implementation of 5010 hopefully provided us with some great lessons that we can use. We found that the quality and quantity of the testing for 5010 was not adequate. Many providers depended upon vendors who said they were ready but had not performed end-to-end testing. Other providers simply relied on a vendor or a clearinghouse or payer saying they were ready and did not do any testing. Today, there are still providers who are relying upon their clearinghouse to convert a 4010 transaction to 5010 and transmit it to the payer. CMS has stated that this type of activity will cease October 1st, 2014. The intent of extending the deadline was to allow facilities and providers additional time to develop implementation plans, and if they already had developed an implementation plan, to allow facilities and providers to have additional time to test with clearinghouses, vendors, and payers. If your organization has not developed an implementation plan, we hope that we are providing you with compelling reasons to do so now. The first step in creating an effective implementation plan is in designating someone to coordinate this project across your organization. This individual should identify and engage all stakeholders immediately and develop a timeline. One buzz phrase in the industry associated with ICD-10 is risk mitigation. This slide lists industry-wide risks involved with ICD-10 that should be addressed by top leadership. One advantage of using a project manager or centralized coordinator for your ICD-10 project is to ensure communication where needed and provide accountability for various aspects of your project. Consider that there are several departments across your organization, and it's easy for seemingly small details to fall through the cracks. A project manager designated for ICD-10 who is organized and takes initiative should help ensure that there is a communication across all departments and stakeholders and prevent omission of details from your ICD-10 project. Elements of your ICD-10 project include planning a comprehensive and realistic budget. For example, does your organization require system upgrades to accommodate the code set? Will any of the vendors with whom you do business be passing on their cost of implementation to you, the consumer? What is the cost of training individuals? This cost not only includes training, but any lost productivity due to time spent in training. There are concerns relating to productivity from coders with ICD-10 coding, as it typically takes longer to code in ICD-10. Some coders plan on retiring prior to implementation. Is your organization adequately staffed? Be prepared for a bottleneck in claims processing after the implementation state. Included in this budget might also be the industry standard 3 months revenue in reserve in preparation for possible claims delays associated with the implementation. As mentioned before, your project leader should identify all stakeholders. This can include vendors, your clearinghouse, payers, physicians, coders, compliance, HIM, administrative assistants, and so on. Make sure responsibilities are well defined and communicate who is accountable to whom. The success of any project relies upon developing a realistic timeline and sticking to it. October 1st, 2014 will come whether or not your facility is prepared. The CMS website is a great place to start when developing your ICD-10 timeline and plan. One of the strengths of the ICD-10 CM code set is the granularity. That is, the level of detail it provides. For example, socioeconomic factors such as exposure to first-hand or second-hand tobacco smoke, non-compliance with prescriptions due to lack of funding are just the tip of the iceberg when it comes to using codes to tell the whole story. The depth and breadth of this information can affect quality metrics in the years to come in ways the industry never conceived. Consider the fact that ICD-9 is more than 30 years old. Medicine and patient care has changed a great deal in that time. Magnetic resonance imaging was not as widely used then as it is today, and all cardiac bypass surgeries were performed with an open approach. Today, some cardiac bypass surgeries are performed totally endoscopically with the use of a robot. 30 years ago, MRSA was not a common term. Today, it is a common acronym in the healthcare community, well known to most. The advantages in technology and diagnostic capability are no longer able to be described within the ICD-9 CM code set, as it has no room left for new codes. Since the industry has used a code set to measure quality that is not only obsolete, but incapable of further expansion, it is difficult to foresee the impact the ICD-10 CM will have. Quality metrics play a large role in the industry today, with incentives paid by CMS to participate and provide data. In the very near future, instead of receiving incentive for participation, providers and facilities will be penalized for non-reporting. As the code set is implemented, quality programs will adapt to accommodate the detail in the code set. Will your facility be prepared or be left behind? The level of detail allowed by ICD-10 CM enables a great deal of information to be shared in a handful of codes. If documentation does not provide enough information to use the most specific ICD-10 code, it can decrease reimbursement, delay reimbursement, or cause the claim to be denied. All of these increase the cost of healthcare and administrative effort in claims adjustments and provider queries, not to mention lost productivity. A community hospital can work with all vendors and its payers to perform end-to-end testing prior to October 1st, 2014 to be prepared for the diagnosis coding detail required by a payer. End-to-end testing consists of charge capture, transmission of the code to the billing system, any processing through a claims scrubber, and transmission of the 5010 transaction to the payer with a return 5010 transaction from the payer with adjudication of the claim. Another buzz phrase in the HIM and HIT industry is clinical documentation or improvement, or CDI. Without adequate documentation to provide the most specific code possible to describe a condition or reason for an encounter, a coder will either have to select a less specific code or query the provider. We have already explored what might happen with a less detailed code. Larger facilities may designate a CDI specialist to review existing documentation for trends that will hinder ICD-10 coding and make recommendations to providers on what additional information is needed. Community hospitals may not have this level of resource. Part of your ICD-10 project should include designating someone to provide ongoing CDI feedback to providers. This individual can be a coder or HIM professional. CDI feedback can be performed by coding today's production charts in ICD-10 and identifying missing data elements. Measuring that information is important so as to effectively communicate the need for better documentation to providers and provide a baseline for improvement. And now, here's Kathy Jennings, Manager of RevCycle Plus Education, to tell you about code set assessment and training.
Thank you, Elizabeth. I think the first important thing to remember is that not everybody in your organization will need the exact same type of training. AHIMA estimates that coding staff working outside the hospital inpatient setting will require approximately 16 hours of ICD-10 education. Personally, I think that may be a pretty conservative estimate. The training for outpatient coders should focus on ICD-10 CM and not PCS. Conversely, inpatient coding staff will require approximately 50 hours, that's 50, of education because they need to learn both ICD-10 CM and ICD-10 PCS. All of the hospital coding staff, regardless of whether they code inpatient or outpatient charts, should complete their comprehensive ICD-10 education not more than 6 to 9 months prior to the compliance date. Completing training too early may result in the need for retraining due to lack of retention. Also, don't train too late. Rush training can also result in a lack of retention of the information. So timing is everything with training. So, does the clinical documentation really need to change for ICD-10? Oh, sorry, skipped a slide. After you complete training for ICD-10 with the coding staff, you also want to be sure to find a way to assess your coding staff's proficiency with ICD-10 so that you can provide additional training to address any weaknesses. Your ICD-10 coordination manager should assess the staff to identify common inaccurate coding decision-making, clinical documentation errors, and productivity lags. You may need to retrain coding staff to make sure that they are selecting the correct codes and following the new coding guidelines, as well as provide education to providers on documentation improvement to make sure that the coders have the necessary information to select the most appropriate codes. Then you need to assess any productivity lags to identify any additional staffing needs. Remember that not all coding staff will require the same type or amount of ICD-10 training. Training for coding staff that works in a specialty area should focus on the code categories most applicable to that particular patient mix. After the initial ICD-10 training, you'll want to have someone address any frequently asked questions, someone to create quick reference sheets to help the coder's productivity, someone to make sure that the software used for the coding provides some system user prompts to lead the coders to the best code, and then someone to provide refresher courses as needed. So, does the clinical documentation really need to change for ICD-10? That's something that you'll definitely need to evaluate, and I suggest a team between your coders and your providers. Are there any details that may need to be coded to arrive at the most specific code for ICD-10? The new codes may affect both the facility and the physician payment, since some insurance companies have already announced that they will not pay for unspecified codes. Also, additional specificity may eliminate the need for requests for additional information from insurance companies, thus facilitating quicker turnaround on claims payments. The new codes available under ICD-10 CM allow for better statistical tracking of accidents and illnesses. That better tracking should allow for better patient care. So, what type of clinical documentation improvement may need to occur? I definitely don't think the physicians need to learn the whole code set for ICD-10-CM. They just need to know what information it is that the coders need to provide the highest level of specificity in the codes. And I wanted to provide just a few quick examples of the types of things they should look for. So for illnesses, simple things like, is it acute or chronic? What is the specific type of illness? Is there a specific location? Do you know an organism or other underlying cause? Are there complications? If applicable, is it right, left, or bilateral? Your providers may be providing some of these now, but it's a really good time to take a look at the documentation and make sure that that information is available. Here are some more examples for injuries. Obviously, injuries are very common in the ED. So for a head injury, is there a concussion? Is there edema, hemorrhage, loss of consciousness? If there is loss of consciousness, how long was the patient unconscious if that's known? For fractures, exactly which bone is it and what part of that bone? I have to admit that I have not seen it uncommon in ED documentation for them just to say radial fracture. Well, what part of the bone is it? Is it open or closed? Is it displaced or non-displaced? What type of fracture is it? Is it physeal? If applicable, again, right, left, or bilateral. You'll see right, left, and bilateral very much as a recurring theme here. For open wounds, is there a laceration, avulsion, puncture wound, open bite, or other, a foreign body? Again, right, left, or bilateral. And then for other types of injuries, just in general, what type of injury is it? Sprain, strain, puncture, what is it? Specific location. In ICD-10, there's also a difference between subluxations and dislocations that we didn't necessarily have before, and the same goes for sprains and strains. And again, right, left, or bilateral. So I know that that's a lot of information, particularly if you want to go at your providers right now. You don't want to throw all that information at them at once. So I have my top 5 coding tips, and these are the things I suggest you actually start working on as soon as possible. Is the physician specifying or the mid-level provider specifying acute, chronic, or persistent? Those are across a lot of the diagnosis codes that are very common in the ED. What's the specific anatomical location, including laterality? What's the specific type of illness or injury? Are there any complications or manifestations? I know that that's a hard one to pull from documentation today, and that is not exclusive to ICD-10. Is the condition due to another underlying condition? I don't think I can make the point too strongly, and it's in big red bold letters on the slide. Specificity is everything with ICD-10-CM coding and payment. And now I'll turn it back over to Carrie.
Thank you, Kathy. So just to reiterate and recap a little bit of this is additional specificity can eliminate the needs of those requests and going back to HIM, maybe from some of that clinical documentation, taking a look at maybe your EMR and does it achieve the necessary specificity required, and ask your vendor when are they going to be providing that update and prior to the implementation date. Making sure that all your software is ready prior to the implementation of the ICD-10-CM. And again, I don't think we can stress enough to test and test and test again. So what can you do today? A few things that the RevCycle Plus group of T-System offers is an assessment. We can actually take a look at some of that documentation today, maybe look at some of those documentation deficiencies, and give you a benchmarking tool of where you are today with ICD-9 and where you need to be, and maybe focus on some of those areas to determine where you might need additional training to prepare for ICD-10. We could do this assessment that is a no cost, it's no obligation, completely confidential. There's little time that's required to gather the information. We typically like to take a look at about 100 charts. And again, we're going to give you some really good information, give you those baselines around the ICD-9 and where you are today and where you should be around the ICD-10. So I guess now we can open it up for some questions.
All right, we do have one question, and we'll just also give everybody a little bit of time if they want to type up a question. But the first question is, what is the estimated cost of training a coder for ICD-10 CM?
Oh, that's a good question. We've actually been asked that by some of our clients. And in some of the research that we've done, depending on geographically where they're located and where the training is actually available for the coders, when you calculate the time and travel, the cost of travel, whether it's by air, hotel, the actual cost of the certification that they're attending, it's between $3,300 and $3,500 per person. So that's a kind of a number to keep in mind when you may be budgeting for those training costs.
Well, we don't have any questions at the moment, but we can give everybody just a couple of minutes here to see if they think of anything, and then we'll go from there. Okay, seems like everybody is wanting a copy of the slides. So when I send you guys out the recording tomorrow, I think I can also send you a copy of the slides, if that's okay with you, Carrie.
Absolutely, and maybe if they want to include our contact information, if they have any other specific questions they might think about, they can feel free to contact any one of us.
Absolutely. So tomorrow I will send all of you attendees the recorded version of the webinar and also the slides, so you guys can have that as well. And I'll have Carrie's contact info. If you guys have any questions, you can just send her an email. Okay, I do have another question. What type of training do you recommend for nurses?
This is Kathy. I think a lot of that is also going to center around documentation improvement and making sure that all the details are there for the coder. Of course, the diagnosis that's coded as the clinical impression on a claim definitely has to come from provider documentation. I have seen cases, and specifically on handwritten records, when it's difficult to read the provider's handwriting, sometimes the nurse documentation does help guide the coder. So if they can also be trained the same type of provider documentation improvement, I think that can do nothing but help. Going back to those slides with things like acute and chronic and laterality, that can be a huge help to the coder.
And that's also something that we take into account when we take a look at these charts during an assessment. We're not just looking at the provider documentation, we're looking at the nursing documentation as well, and can provide some feedbacks of where there might be some documentation deficiencies.
Okay. Is the documentation important for MDs or nursing also?
This is Kathy again. I would say that it's all important, just because there are some things that are not necessarily diagnosis code related that we also need to pull from the nursing documentation, particularly on coding for the facility side. A lot of that information on the facility side coding comes from the nursing information, so it's also critical that the nursing documentation be as complete as possible. And as Carrie mentioned, that would also be a part of the assessment. I think all of you know, and I'm kind of getting off the track from ICD-10, that nursing start and stop times on infusion can be a huge drain on a facility. And that's just an example of one of the nursing types of documentation that can affect your revenue.
This is Elizabeth, and one particular example of where nursing documentation can affect ICD-10, a lot of times a physician may not document the exact nature of an injury, what the patient was doing when a patient was injured, and that there's a much greater deal of detail that can be captured in the ICD-10 CM code set. And so often we can look to nursing documentation to provide the nature of the presenting problem.
Another one says CEUs for AAPC.
This is Kathy. We don't actually have CEUs for AAPC for this presentation. This was more of just a general overview. I'm not sure if that was the question or not.
Yeah, that's
there is the okay. Not for this presentation, actually.
Also, here's another one. What if the documentation for the doctor and nurse are contradictory? Whose would you use? Can it be based on the rest of the documentation? For example, wrong side documented by one or the other.
Hi, this is Kathy again. You guys are probably going to get sick of the sound of my voice. If the nursing and physician documentation are contradictory, it obviously depends on exactly where they're contradictory. Like I said, the clinical impression itself would need to come from the physician's documentation, and it would depend on your facility's policies, but I would either send a query back depending on the contradiction, such as one time I saw one where, you know, all the way through the chart it says shoulder injury and the physician's mentioning a hip injury. That I would query the physician on and make sure that we've got the right documentation included in that chart, because things do get mixed up from time to time. However, if it's a simple specificity issue, I would probably default to the physician's documentation, since that's where the information for diagnosis coding really should come from.
And we have another question, and I don't know, Carrie, if we know the answer to this, but it says, will you provide any webinars for physician-specific training?
Yes.
Yeah, actually, I'm glad that question came up. We're actually looking into that. We are trying to define what format that's going to be in. We're looking at the content, and absolutely, we feel that that is a very, very important part of helping a facility transition to ICD-10. So we're going to be probably soon, I would say in the next month or two, looking at something that would be more specific to physicians.
Okay. Just a couple more questions. Does T-System hard code the diagnosis that the MD enters?
Depends on the facility.
It depends. That really depends on the facility and what the facility has chosen as part of their best practices. Something that we obviously suggest is that, although it may be hard-coded, that regardless, that documentation really is the best practice, should be reviewed by a coder as well. And that's certainly something, if we want to take that conversation offline, if we weren't able to address that maybe to the detail level that you needed, we'd be happy to have that conversation.
Okay, one last question. How does your system handle queries? Can they be sent to the MD through T-System, or do we still have to speak with them one-on-one?
Actually, what's nice about the RevCycle system is the reports that are provided. We have many, many reports that are specific around the documentation deficiency, and these reports can be automated. They're in a dashboard format. So maybe today, some of that information that you might be trying to gather on a manual process, maybe a pending chart, that can be automated because maybe you've gone through and there's additional documentation that's needed on the provider side. Again, some of those things can be automated in that case. For instance, if we're talking about this type of scenario, one great report that we love is the provider deficiency report that actually gives a detailed level of what the provider actually documented around medical decision-making, review of systems. It shows what was actually billed, but it also shows that had there been documentation further in these more specific areas of what could have or potentially been billed. So there's there's more than 40-plus reports around those types of things, and we'd be happy if you want to contact me to provide you some samples of those.
Great. Well, I think that is the last of the questions. If you guys have any last-minute questions, feel free to email me, and I can get Carrie to answer those for you guys. So we would like to thank you for attending today's webinar, and this concludes the webinar, and on behalf of the T-System, thank you so much for joining us.